everyone, and thank you for the opportunity to give you a very quick 2 to 3 minutes high level on residual inflammatory risk. My name is Brittany Weber. I'm the director of the Cardio-Rheumatology program at University of Texas Southwestern Medical Center, and really excited to be able to talk to you about why we should be thinking about inflammatory risk and how exciting the future is to come. So to begin, the concept of inflammation is not new. Indeed, Virchow first described the infiltrate in the arteries in the 1850s. And then in the 1900s, multiple advancements revealed the key role of endothelial activation and leukocyte adhesion molecules. And fast forward to the 1900s to the 2000s, where we've really taken that fundamental findings down to the mechanism, and we now appreciate the important role of the innate immune system and the adaptive immune system. And this has been corroborated by both clinical and epidemiological evidence, highly amounts of mounting observational data, as well as randomized control trials that have now demonstrated that inflammation reduction via risk factor treatment, and more recently supporting for direct inflammation targeting. So, to break it down into simple terms, we now know that inflammatory cells are an active component of atherosclerotic plaques. We also know that inflammation contributes to the plaque formation, the progression, and the complications, including thrombosis. Furthermore, we know that inflammatory biomarkers predict atherothrombotic events. And so, what is a key biomarker that we can utilize in clinical practice? So, one biomarker, as mentioned, is a high sensitivity C-reactive protein. It's widely been available. It has been shown to be predictive across primary and secondary prevention cohorts. So, what is CRP? Well, it's an acute phase reactant. It's produced by the liver. It has a long half-life. It's not affected by things such as food and diurnal variation. It's also can identify patients at increased risk of atherothrombotic events. And this just shows you the pathway by which these works through, starting with the top where the activation of the NLR3P inflammasome, activating IL-1 beta, ultimately activating IL-6 to driving CRP reduction. And then the multiple agents that are being tested as anti-inflammatory therapies shown in the boxes along this pathway shown here. So what do the levels mean? So one way to think about CRP is what is low, intermediate, and high. We generally think of greater than 3 milligrams, or often we'll even say greater than 2 milligrams. That's a cutoff that many clinical trials that have used for CRPs and enrollment criteria is being elevated. It's also important to remember when you're putting this into clinical context that it's an acute phase reactant. So greater than 10, you should consider retesting and excluding acute phase reactions such as infections or other type of acute inflammatory insults that could be driving elevated CRP. So going back to my comment where I said CRP has been shown to be predictive of both primary and secondary prevention. This was one of many different studies that have been published. It's a very important study just released in the New England Journal of Medicine that demonstrated that a single measure, combined measure of hsCRP, LDL, and lipoprotein A was predictive of incident CVD over a 30-year period among 27,000 healthy women, according to their baseline status. And this just shows you the predictability in the different quintiles of all the three biomarkers. And you can see the importance of CRP in this study as well. Furthermore, we've had data that demonstrates that CRP is a powerful determinant of cardiovascular death, irrespective of LDL, among statin-treated secondary prevention patients. This was a pooled study, a pooled analysis that looked at 3 large trials of 30,000 patients that were statin-treated and demonstrated that CRP was predictive of risk even among patients when their LDL was controlled. You can see here on the right versus LDL that was above 70. Furthermore, if you remember that little algorithm I showed you that IL-6 sits upstream and activates CRP. And we've now have appreciated evidence for the last decades now that IL-6 levels are a powerful predictor of cardiovascular events. This is an important study that demonstrated over 20 years ago by Dr. Ricker the role of increasing levels of IL-6 and future risk of myocardial infarction, as well as this has been corroborated on the right with multiple different studies that have looked at this with increasing data showing the role of IL-6. Furthermore, IL-6 has also been demonstrated to be important in the association of the risk of heart failure with reduced ejection fraction. These are just two different studies demonstrating that point that IL-6 was strongly associated with the risk of developing HFpEF, new onset, in a cohort of community dwelling participants without known heart failure. And another study on the right that demonstrated among almost 1,000 participants that increasing IL-6 was associated with the risk of developing new onset heart failure in the PREVENT study. So, quick take. This was a short talk here, but I hope in this high level you can now understand that residual inflammatory risk refers to the persistent heightened risk as a result of inflammation, even despite when your cholesterol levels and other risk factors are managed. We talked about the role of hsCRP as a biomarker that we can be utilizing in clinical practice, as well as the upstream driver of IL-6 that ultimately leads to the production of CRP, and also all the ongoing therapeutics that are being tested along this pathway. So thank you very much for your time, everyone listening today. There's my email on the bottom left if there's any questions. Thank you.